Welcome back to The Deep Dive. We dig into the sources so you get the essential insights fast. Today, we're trying to get inside one of the most intense workplaces imaginable, the emergency department. We want to decode the mindset, the way of thinking of an emergency physician, or EP.
Yeah, this is really interesting because we're not working from a textbook here. Our source material is actually a list of, I think, 30 common interview questions for EPs.
Right.
And these questions, well, they tell you a lot about what hospitals really look for. It's not just about medical facts. It's this blend of speed, ethics, communication, all under, immense pressure.
Exactly. So our mission today is to unpack these questions and really get at the core framework, the thinking that lets these professionals operate when, frankly, pausing could be disastrous. If you want that shortcut to understanding the EP mindset, you're in the right place.
Okay, let's dive right in. The sharp end, maybe. Section 1. Clinical competence, the split-second decision makers. The absolute core challenge here is making good decisions fast when there's just no time to waste. And it starts the second a patient hits the door, right? Triage, that's everything in the ER. Our sources show EPs have to lean hard on standard protocols, like the Emergency Severity Index, ESI.
ESI.
And you need to understand, ESI isn't just about sorting who's sickest. It dictates resources. Does this patient need a nurse now or the doctor, like right now?
Yeah.
It's that first critical fork in the road.
And that system, that triage, it has to work even in the absolute worst case, like a mass casualty event.
Oh, absolutely. In those situations, prioritization becomes, almost brutal. It's immediate, pragmatic. You focus on the most life-threatening injuries first, stabilize them, then move to the next tier. It's about maximizing lives saved, pure and simple.
That sounds like efficiency born from necessity.
It is. And it's built on immediate action. Like the example in the sources a patient comes in, bad chest pain, unstable vitals. The EP doesn't sit around waiting for labs. They're ordering the EKG while giving aspirin and nitroglycerin because they suspect a heart attack. That's acting on protocol-driven suspicion before you have absolute proof. High-velocity thinking.
But, okay, here's where it gets tricky, right? What about the really rare stuff? The things that don't fit the common patterns?
Yes. That's the constant challenge, maintaining a really broad differential diagnosis. There's an anecdote in the sources about exactly this.
Tell me.
Patient, severe chest pain again, but the initial heart tests, normal.
So most people would breathe a sigh of relief, maybe?
Maybe. But this EP didn't. They thought beyond the usual suspects. Their thinking led them to order a CT scan, and boom, confirmed a rare, very deadly aortic dissection.
Wow.
That shows the mental tightrope they walk. You have to trust the protocols, rely on them,
right,
but also know when the picture just doesn't add up and you need to push further.
So how do you cultivate that ability to, override the obvious when it doesn't fit?
It really comes down to structured thinking, even under pressure. When things go sideways fast, like a patient deteriorating rapidly or complex trauma cases, the bedrock is always immediate stabilization.
The ABCs.
Exactly. Airway, breathing, circulation.
Yeah.
And following established guidelines like ATLS Advanced Trauma Life Support, these protocols act like a mental scaffold.
A scaffold.
Yeah, like even if the EP is tired, stressed, surprised, they follow those steps. Secure the airway, keep the neck stable, check breathing, check circulation, and constantly reassess how the patient is responding. The protocol keeps them on track.
Okay, so we've got the clinical speed, but speed alone isn't enough if the team isn't working together. Let's move to section 2. Teamwork, stress, and leading the chaos. How do they manage a team in that kind of environment?
Well, the first thing isn't clinical at all, it's personal. Resilience. The sources are really clear on this. Stress management isn't just a nice to have, it's actually a safety measure. Things like prioritizing tasks effectively, maybe mindfulness techniques, exercise, sleep, diet. They're not just for wellness. They're about keeping your brain sharp so you don't miss that tiny detail when things get crazy.
And burnout is always lurking, I imagine.
Huge risk. The sources stress things like work-life balance, actually taking time off, leaning on colleagues for support. It's like the system knows you need to maintain the instrument, the doctor themselves, for sustained performance.
Makes sense. And when they're performing, the communication has to be almost military-like.
Tactical is a good word. The sources point to tools like really clear, concise language and something called closed-loop communication.
Which is?
Simply repeating instructions back. Give 10 milligram morphine. Okay, giving 10 milligram morphine, it sounds basic, but it cuts out assumptions, prevents errors when it's loud and chaotic.
And that leads to things like SBAR, right? Situation, background.
Assessment, recommendation. Yeah. SBR isn't just filling out a form. It forces structure onto the information exchange when your brain is overloaded.
Yeah.
It ensures the key ask or recommendation gets through clearly. Good leadership there is about making quick decisions and then delegating effectively using these tools.
Okay, but teams aren't always smooth sailing. What if you, as the EP, disagree with the colleague's treatment plan in that high-speed setting?
Yeah, that's tough. It requires both clinical knowledge and emotional intelligence. The approach has to be professional. First, talk to the colleague privately. Lay out your reasoning, the evidence.
And if they still disagree?
Then you escalate systematically. Consult a specialist, maybe a senior colleague.
Mm-hmm.
Patient safety is always the top priority. You use the system to resolve the dispute, not, a shouting match.
Right. And speaking of systems, administrative efficiency comes up too. Documentation, charting, everything.
Well, it's critical, not just for passing information along for patient care, but for legal protection too.
Yeah.
EPs have to be wizards with the electronic medical records, the EMR.
But doesn't charting take time away from patients?
It can, and that's the balancing act. You have to delegate tasks where possible, be efficient, but incomplete or late charting. That creates huge risks later on. It's about covering all your bases, clinical and legal.
Okay, this brings us to maybe the hardest part. Section 3, the ethical and interpersonal tightrope. This is where medicine meets raw human emotion.
Yeah, this can be incredibly draining. Just dealing with difficult interactions is part of the job description. An anxious patient, maybe someone combative.
What's the approach?
Stay calm. Acknowledge their fear or discomfort. Show empathy. Explain what you're doing and why. The goal is de-escalation, trying to build enough trust to cooperate.
What if it's the family disagreeing with a diagnosis? You can't just say, I'm the doctor.
Definitely not. You have to make them feel heard. Really listen. Explain your reasoning simply, clearly. And often, offering to get a second opinion, even if you're confident, can build that bridge of trust.
A huge ethical issue must be patient autonomy. What if someone refuses treatment they desperately need?
That's a cornerstone. If a patient refuses, first, you absolutely have to make sure they understand the consequences. If you don't get this treatment, this bad thing is likely to happen.
Okay.
Second, you have to assess their capacity. Are they thinking clearly? Do they understand? Can they legally make this choice for themselves? If they have capacity and still refuse, you document everything meticulously.
But what about the exception? The life or death moment where they're refusing but clearly need help now?
That's the extreme edge case. The sources say that in immediate, life-threatening emergencies, ethical guidelines might allow intervention against consent if it's necessary to save their life. The priority briefly flips to preserving life, but it's a very high bar, legally and ethically. You'd reassess capacity the moment they're stable.
Wow. Okay, let's touch on specific patient groups. Pediatrics. Kids in the ER must be terrifying.
It's a different world. Kids can look fine, and then crash incredibly fast. So it's all about super careful, constant monitoring. And the communication has to be right for their age, keeping them calm, involving the parents completely.
And patients dealing with substance abuse or mental health issues.
The approach has to start non-judgmental, empathetic. But critically, you do a full medical workup first. You can't assume it's just mental health or substance use. You have to rule out physical causes.
Then what?
Then you might use validated screening tools like CAGE for alcohol, maybe PHQ-9 for depression to assess. And then it's about initiating treatment or, more often, referral, all while guarding their confidentiality fiercely.
And the opioid crisis, that must hang over every decision about pain.
It absolutely does. It's a constant balancing act. The goal is multimodal pain relief using non-opioids, nerve blocks, other techniques first. If opioids are truly necessary, it's the lowest effective dose for the absolute shortest time.
Plus education.
Essential. Educating the patient on the risks, side effects, potential for misuse. You're treating their pain, but you're also aware of the much bigger public health picture.
Let's talk about two really tough communication tasks: breaking bad news and end-of-life care.
Yeah, these require immense sensitivity. For bad news, it's about clarity and empathy. Simple language, no jargon. Give them space and time to react, process, ask questions, offer genuine support.
And end-of-life.
Similar principles. Honesty, deep respect for their wishes. That means knowing about advanced directives or talking closely with family. Palliative care involvement is key here, focusing entirely on dignity and comfort.
And underlying all of this are confidentiality and cultural sensitivity.
Not negotiable. Strict HIPAA adherence, secure records, only discussing cases with necessary personnel. And cultural competence means actively learning about different beliefs, using interpreters effectively, respecting practices that might differ from your own. It builds trust.
Which brings us to our last section, accountability and lifelong mastery. Because in this field, mistakes have huge consequences and you have to keep learning.
Right. Accountability really shows itself when something goes wrong. Let's say a mistake happens, wrong medication dose, because a chart was misread.
What's the protocol?
The sources are clear. Immediate action. Inform the team. Monitor the patient very closely. Report the incident through official channels like risk management. Transparency is key.
But it's not just about reporting, is it? It's about learning.
Exactly. The crucial step is figuring out why it happened. What broke down in the process? Then you implement checks, change routines, whatever it takes to prevent that specific error from happening again. That's how individuals and systems get better.
Okay, here's a tension I see. You're saying follow protocols rigorously, ATLS, SBIR, reporting errors. But you also mentioned the EP sometimes has to trust their gut, like with the aortic dissection, and advocate when the tests are unclear. How do they balance strict compliance with that kind of intuition?
That is the art of emergency medicine, isn't it? You follow the protocol until the patient deviates from the expected path. When the tests don't match the clinical picture, that's when experience, intuition, whatever you call it, kicks in.
That's the advocacy piece.
Yes. Like the example of pushing for more investigation despite normal initial tests and finding a bowel obstruction needing surgery, the EP has to be willing to say, wait, something's not right here. Even when the data looks okay initially, they have to fight for the patient when doubt creeps in.
And that constant need to learn to update that intuition drives professional development.
Absolutely. It's not easy with the demanding schedule. They use online learning, go to conferences, but maybe the most powerful learning happens day to day, reflecting on tough cases, near misses, unusual presentations. Every shift is a potential lesson.
And finally, teaching the next generation, mentoring.
Yeah, and good mentoring isn't just dumping facts. It's about supervised, hands-on experience. Critically, it's also about reinforcing all those non-clinical skills we've talked about. The communication, the teamwork, the stress management. Those are survival skills in the ER.
So wrapping this all up for you, our listener, what does it take? Being an EP seems like this incredible fusion. You need that split-second clinical mind, disciplined teamwork, using tools like SBRR and closed-loop communication.
And deep emotional intelligence. Navigating incredibly complex ethical situations. Autonomy, end of life, cultural differences, pain management. It's a huge range.
The role isn't just defined by how fast they make decisions, is it?
No, I think it's equally defined by the rigor of their self-reflection, how they learn from the wins, like catching that rare diagnosis, but maybe even more importantly, how they learn from the mistakes, the errors.
So that commitment, that constant cycle of action, reflection, and improvement, trying to make every single encounter a learning opportunity, that seems to be the real heart of the EP mindset.
I think that's right. That relentless drive for self-improvement, for refining judgment, might be the most crucial quality